Welcome.
The Pathology Innovation Collaborative Community is a regulatory science initiative that aims to facilitate innovations in pathology, as well as advance safety and effectiveness evaluation. The PI Collaborative Community aims to harmonize approaches to speed delivery to patients through collaboration in the pre-competitive space. The PI CC is open to all stakeholders, public or private, including but not limited to academia, industry, healthcare providers, patients, and advocacy groups. Meetings of this kind are an example of lawful activity under federal antitrust law because the focus of the meeting is on government action or policy, including the industry's responses or positions taken with respect thereto. However, antitrust monitoring is needed for companies' own protection since they are direct competitors meeting together. These meetings need to stay within protected subject matters and need to be monitored so that they do not stray off into inappropriate areas, such as pricing and price terms, sales and service territories for particular products, customers and customer territories, each company's individual decisions regarding selection of suppliers or customers, marketing plans and especially future marketing plans or new product offerings, other proprietary or competitively sensitive information. Today's meeting will follow the written agenda, and there will be no discussion of pricing or other prohibited topics. If the discussion veers into those topics, we will terminate the discussion. If you have any questions or concerns about the propriety of the discussion, please raise it immediately, and we will take a break to determine how best to proceed. The Medical Device Innovation Consortium acts as the formal convener, and we will follow their conflict of interest policy. For additional information, we defer to our Code of Conduct and our website, www.pathologyinnovationcc.org. We look forward to moving the field forward.
Hey, Joe.
Hello, hello. Hi, Paul, Rama, Laura. Hey.
Hi, Joe.
Hello. Pleasure.
Hi, Joe and Paul.
Hello.
Hi, Laura.
All right.
I'm
Thank
gonna
you.
have to drop off a little bit early, so just let you know. That's why I'm leaving probably about 3:50.
Perfect. Yeah, I think we made some good progress, and I want to show you a few things that we put up, and then maybe we can discuss sort of next steps. I'm going to show you real quick because information blocking was somewhat related, but yet it was relatively, I would say, specific regarding 21st Century Cures Act. And there was a recent update. So quickly, this was 9/14, so last week. This specific seminar happened, and it was done by ONC. And with respect to pathology, I think this is the key slide, and I just wanted to briefly show this real quick. So, as you know, the information blocking component of the 21st Century Cures Act outlines that you're not allowed to interfere with availability of test results. And at least for pathology, this was the practice examples that they demoed. And they had several examples which are all in this PowerPoint here. But the key element is, so would this be considered an interference with the access to patient data? And if so, that would obviously cause some problems and non-compliance, and thereby potentially even fees. But so if I establish an organizational policy to delay the release of all lab results until the ordering clinician reviews the results for potential risk of harm associated with release, there was a clear check mark here that would be likely interpreted as an interference. And importantly, how they defined this is that practices will be evaluated on a case-by-case basis, etc. So practice likely to be an interference may not be information blocking if the actor's practice is required by law, etc. So there's a lot of exceptions. And you know, this by law is especially something when talking about the individual state laws. But this checkmark here means if you, for example, work in a practice that has certain, blocking exceptions for new diagnosis of cancer, etc., that would be likely considered an interference. And these particular FAQs and answers we added here, so we won't have time to go over these in all of the details, but I thought that I just wanted to show this. And the video of this session is also available here. And then the rest is sort of just the basics. So this all refers back to the 8th section, which is the electronic health records information blocking. So I just wanted to start off with this because I think this is affecting a lot of issues or a lot of labs, at least in pathology. I don't know if that is directly applicable, but since this is such a specific thing about not necessarily privacy, but it's related to it, we parse that out into like a separate sort of project. And the privacy pilot so far has sort of this section here, like we discussed it last time. And so I just figured I wanted to share this. Are there questions about that, or does that make sense so far? Have you had any interactions or any sort of contact with information blocking, Rama? No?
No, not really. So what sort of a contact are you talking about, John?
So the idea behind this entire 21st Century Cures Act is access and patient access, etc. Okay. And a long-term problem was that if you switch physicians from one to another, that there may be companies that would charge fees in preventing you from having access to your own medical record. And that's a very, very broad topic. So, and that practice is referred to as information blocking, and the Act defines that as any practice that interferes with preventing access to EHR information. Patient advocacy groups have been fighting for this for decades, and the 21st Century Cures Act in its final version was, I think, approved 2016, but 5th of April this year, this particular deadline for implementation was reached. So if you now continue to interfere or prevent patients from having access to the medical record, that is considered an interference, and if you do it systematically, you may be in non-compliance with it. But there are many other sections in there. For example, interoperability is included as well. So the key element that I think I wanted to clarify, and I see Joe Sirentrappen has joined as well, is that this particular section of lab results, and in particular when patients find out about, for example, cancer through an electronic push on their cell phone, has resulted in some concerns about whether those practices are okay or not. Now, patient advocacy groups see that in a longer scale thing than the pathologist who's confronted with a concerned clinician who says, my patient just called me really concerned because he or she has cancer. So there's a short-term and a very large-scale long-term issue related to this. But this part here coming directly from ONC explaining that if the release of all lab results is delayed, for example, until the ordering clinician has reviewed the results, that's definitely or likely be considered an interference, so therefore would not be correct and cannot be generalized or cannot be, and all they put in bold here. Hey, Joe.
Hey, I just joined. Well, I'll tell you what MSK has done, at least. Gosh, this is pretty hot a couple months ago. I mean, everything seems like it's an eternity. So, I mean, it could have been more. But the last time I checked, we delayed. I think we had such an outcry. And I think the argument was that we were hoping that legislation might come down to really nuance the instantaneous of it. I think our clinicians the patient advocacy groups really wanted it. But this might be a case of them not necessarily, knowing exactly what they want, because there's consequences, as we mentioned here, with releasing results before you've had a proper talk with your clinicians. So the argument by the MSK legal team, last I heard, was that it has no teeth. So ONC may mandate it, but they're going to say, what are you going to do? The MSK is taking the stance, what are you going to do about it? And I haven't heard them saying, well, all right, this is what ONC or through HHS has now done to us by doing it. So, and they're hoping that maybe some nuances in regulation may come down the pipeline. Now, it's been months, so maybe nothing's happened, but we do delay, I forgot how long, maybe 2 days or something. We don't do it instantaneously. Yep. And we're just violating it. And I think we're just basically daring them to say, what are you going to do about it? So I don't think other institutions have done that, because ONC, they can make a mandate, but whether HHS follows through and penalizes you, or whether MSK is situated to say, well, we don't get this many of, I don't know, Medicare, Medicaid, they might actually have that leverage. And so that positions them to be able to do these type of dares. But as far as I know, I think we've delayed ours by like 2 days or something like that, just so it gives us a breather to be able to consult the patients.
I haven't heard any kind of complaints within the context of the patients or clinicians, but I do know our IT team at Tricor was kind of discussing this issue. I honestly don't know what the resolution was on that. So yeah.
I don't think that there is, as you said, a clear path for what if you're non-compliant with this. But there are obviously other exemptions. So a lot of people say, well, if you receive the results at any time, that's sufficient, versus some say, as pointed out here in the FAQ, delaying the release of results for any time is already interference. So again, this was not intended to derail our privacy conversation, but this is a big deal when it comes to, if there would be some consequences, I think a lot of people have to change their practice. I believe we also delay this, but for various reasons. But I think it's just fair, and I wanted to point out that this is like a separate section and project in the same sort of projects folder under the PyCC, just mostly for information, meaning we're spreading the information of information blocking.
What does, I mean, I don't mean to derail it, but what type of tools does ONC, or weapons does the cudgels does ONC have to basically force people to do it at instantaneous rate? Because that's the part I wasn't too sure, but MSK Legal gave me the impression that they had no teeth, or at least at this point, they didn't really, they don't have the bullets. They can put the law out, but they don't have the bullets to do something about it. And I'm not exactly sure about that technical framework.
I'm not too familiar, but the fines have been defined in the 21st Century Cures Act. And those are, I think, up to $1 million or so in fines for messing with this. But the enforcement of that would require that someone is willing and able to even audit that. And I'm not sure how that is going to be implemented, right? So like monitoring this, I think it will probably coming through the patient advocacy group. So we can probably reach out to some of the collaborative communities or some of the connections with our patient advocacy groups to figure out what the advocacy groups are thinking about this. I mean,
how are they feeling about that in terms of, this is one of those, be careful what you want, because there are consequences to like cancer diagnosis in particular, getting them a little too early before you chat with somebody. But they may want this. They may want it anyway, regardless of the cost. And I'm curious about that.
So I said earlier, there's like a short-term and a long-term consequence of this. So the short-term is always like concerned, and I think most pathologists would, or most oncologists would initially say, I don't want my patient to find out from an anonymous interface. But the literature is actually pretty clear that finding out and then reading about it and coming informed to that first conversation has actually longer term no harm impact. Quite the opposite. Patients are not completely in shock and can process information better. I will pull up some papers and I add those. Maybe Ulla, we can add that to the information blocking page. I haven't done a full systematic literature review on this. That's just sort of from, screening the literature on that. I believe some of the folks over here at Beth Israel, if I recall correctly, alongside other institutions, have done some really good studies on that. So I have to double check that, but I think that was my impression.
Joe, is that approach that MSKCC has for all tests or only select tests?
Just anatomic pathology results.
Okay.
I think everything else is instantaneous, but
Okay.
for
Yeah.
first time buy, I believe, I mean, we can't separate them. We don't know how to flag first time, but I think for anatomic path reports, we hold them.
Including molecular?
Molecular is so slow anyway. So, but yeah, I think so. That's so slow that I don't think it really matters.
Sure. Yeah.
All right. So back to the topic. I think we had, our sort of idea of, I don't know, several components related to privacy, and I think the general topic and outline. I don't know if you had a chance to look at the project overview, and Rama, I think if that's okay with you, and or Laura and Ulla, we can add you to the authors of this. So if you haven't seen this, please take a look. I'll send the link here real quick, so you have that. And I think that would be sort of a starting point to say that the information and other resources would be there. I added 2 or 3 things here. Starting on the bottom here, the national patient identifiers. This is mostly from Joe's interview with CAP is in here. We have the data integrity groups rally for NPI, and then these 2 papers. One is more sort of ethics, and I think Ruma, you may recognize that. And then, this is from Joel Hedlund, which is more GDPR related, because, at least initially folks were quite interested in seeing how that goes. If you're not familiar with this is a platform largely for AI. So this is a little bit more related to this. And then this was a slide deck comparing HIPAA and GDPR. And I think last time we focused a little bit on this sort of, I don't know, de-identification NPI idea from Joe, and I wasn't sure whether anyone had sort of an update on that or comments, or maybe we can, I don't know, Joe, this is putting you on the spot, but maybe sort of discussing that again.
I think the part I was waiting for was just, I think Laura had some information security experts, just to vet kind of my illustration diagram. Is this feasible? And then we could just post it, because I don't mind posting it. But it made sense for my chief information security person. But I got an extra layer of vetting. And if it makes sense and it's a viable product, then I'm happy to put it up there and have people, the entire community, try to take a hack at it. Like, what's wrong with this framework? Is there something there other than the usual arguments of cost and blah, blah, blah? This is feasible. This is very feasible, and it's a reasonable approach. It just requires a lot of cooperation in building a national infrastructure to be able to take on the load of all these different transactions of verifying identity, But that's the part I think I was just waiting on, And if it's good to go, I'm happy to post. I think I sent it in an email. Just post it.
Yeah, I mean this.
Laura had to jump off, but she sent a note saying that she did pass that the slide that you had sent. She passed it along to a couple colleagues who are going to share it and speak about it. And then she's expecting feedback by next week. So hopefully we can get an answer there.
Oh, that's great. That's great. And I'm happy to explain it if it hopefully the diagram is kind of self-explanatory for a lot of these information security folks. When they look at it, they can sort of visualize it, but I'm happy to explain it a little more. Basically say is it viable? And if it's viable, we should put it out there.
Paul, what did you think? Because I know you're an expert in this topic, especially.
So, the range of discussion has kind of broadened out a little bit. And my area of expertise is really limited to the de-identification side of things, and the privacy uses of data, and the the processes that you have to manipulate the data through in order to share them with external sources. So, as far as just the overall agenda goes, I'm wondering, are we going to try to serve a lot of different areas? Are we going to, or do we want to just focus really on one thing or one area?
So, I mean, obviously the solution that Joe presented is broader. It's like it could be applicable even beyond medicine, I presume. But I think the testing for feasibility usually works with a simple use case. I don't know, Joe.
Yeah, I can try. I don't have the diagram. I don't know where I put it right now. I don't think I have my laptop on me that has it. But the diagram itself, basically the idea is that we're not passing the idea of having a national patient identifier is controversial because, and I give the kind of the incentive game theory model. When you tie an identifier like a social security to something important, like financial information or whatever else, it's that tie-in to something important. That creates a game theory where it's valuable to get that number. The framework I provided, it doesn't pass identifiers around at all. It's tokens.
No. And Joe, I didn't mean to take you off. I get all that.
Okay.
It's a big idea is really my point. And there are, I think, a lot of little steps that have to happen before, we could eat the whole whale, right? Is there something more pragmatic in introducing this approach that we would need to do step by step to try to get buy-in from a larger audience? And what audience is it that we want to attack?
I think the patient groups would be the ones that basically, because right now I think a lot of resistance is from the senator part. Senator Dr. Ron Paul is a big opponent if you start Googling about having a national patient identifier. And I'm obviating that argument because it's not a national patient identifier. It's an identification mechanism. But when you have patient advocacy groups that say, I can't share my results or my treatment was delayed because they couldn't reconcile something. When you have that outcry and you make it public in the sense that the public really wants this. I mean, yes, the problem is that you're going to have the other side basically fear mongering and saying, well, because of this, you're going to have this exposed. And I'm providing my technical framework where that's obviated. But this is where disinformation can get out there. But I think if you're going to get a champions, it's going to be from the patient advocacy groups. I think the hospitals and a lot of, I think insurance companies like it a lot. That's another stakeholder because they would like not having to verify continuously, spending a lot of money for that. Hospital networks probably would be opponents in the sense that this encourages patients to shop around because you basically included the fluidity of patients going around. So right now, off the top of my head, the two big proponents would be the patient advocacy groups and insurance companies that would actually allow these things. And they're pretty powerful.
Yeah. Oh, I mean, that makes sense. And my point in bringing this up is that, if we want to turn, words into action, we're going to have somebody that is going to be a loud advocate for this and wanting change. And it doesn't matter whether the concept is fully vetted out and fully built out, but at least find out whether we can get some support for moving this forward as an actionable item before we spend too many cycles. If we find out that there's a lot of resistance or there's just not enough interest, then we can let it roll, right?
I also think that this is something that we're a small organization in the sense that there are other informatics organizations that are bigger than us, AMIA. I'm surprised they haven't thought of this, but hey, who knows where all these creative ideas end up coming from. But AMIA, AMA, so having the big organizations going to the health insurance companies, to the advocacy groups where they have larger connections, this is how you sort of snowball something.
I think that part we could probably tackle, but what I think, if I understand Paul correctly, is could we build a prototype even with, let's say, using this proposed model to share even fake data across, let's say, the 5 of us, right? I mean, just sort of almost like a single key value pair with an NP, a national identifier in a way to prove whether this is safe and works.
It would be helpful. It would be helpful to have something that people could react to other than just a theory, a very small little desktop model, even to show somebody so that you can get some buy-in. my point is that I'd hate to waste time working on this much further than you already have without having somebody to sponsor us, somebody with some heavy weight to move opinion in the marketplace and try to make this thing become reality. Patient advocacy groups, I think, is a great idea because they do carry a lot of weight. I mean, to Joe's point, I think mocking something up and saying, isn't this something that makes a lot of sense? And then proposing it as something that they can get behind might be a useful exercise.
So Joe, were you thinking that the identifier itself would be exchanged kind of as
No.
the key for the payload? No.
No, actually, I did find it, but now I need to set up another. I need to join on a different laptop to basically share the screen. So, yeah,
but I wouldn't share the concept because we're recording. You know, don't want to get the message out. If we want to,
Okay.
you know, I think that's how I understood you, that you wanted to check feasibility before it's shared, right?
Yeah, I mean, I don't mind this is not official.
Okay,
It's not like
sure.
we're advocating this thing. If it's like a stance, like, yes, we fully support it and we'll go down the tubes if it allows you, it's a hypothetical model. And
Here. So here,
you got it.
Yeah,
Awesome.
yeah.
That's awesome. Yeah.
I was
So the
protecting your idea, man.
Oh, thanks. So, I mean, the stuff in the periphery, these are healthcare networks, hospitals, you name it, insurance companies, whichever entities out there. The idea is that there's actually a national identification server. The purpose is identification, not actually identifiers. It's passing around, tokenizations and having kind of a framework to allow tokens being passed back and forth. But think of the identification server as an air traffic control. It's getting a lot of different messages, transactions, just trying to verify the identity as a patient goes from one place to another. So it requires kind of a national infrastructure to be able to handle the load of all these different tokenizations. But its entire purpose is just to verify identity. So you're not passing identifier, you're passing tokens. You might require certain different pieces of data to a certain nth degree that you need to verify that you are who you say you are, but it's not passing identifiers. There are actually no identifiers being passed around, so there's nothing really to steal from that standpoint. And there's no actual data in the sense of, what's your cancer history, things that will affect life insurance. That's housed locally. The entire purpose of this server is to basically do transactions about verifying identity, and nothing else is tied to it. So you've lessened the game theory model of stealing the tokens or anything living on the server itself. There's nothing that valuable there. You'd have to hack the original source, which actually has the data. So by doing this way, you've basically set up an infrastructure just for identification. But it requires investment and buy-in for something like this on a national level.
Yep. Yeah, I mean, and that's my point. You've fleshed out a really good idea, Joe. But none of us in this group have the wherewithal to make it a reality on our own. You got to get one of the 4 dots to buy in, right? And
but Joe, can I ask? So let's assume this would exist, meaning everything from server to tokens to the appliance.
Yeah.
How would, let's say, this is a payer and this is a hospital, how would the data transaction work through this tokenization process?
Yeah, the data transactions, that's not going to be part of this. This is for them to figure it out, whether it's AHRQ or not. It's just to basically allow the process to go forward. They can, how data gets passed back and forth, that's for them to figure out. Before that step is to verify identity that one's going to go to another. So it's the first step.
The last step would be it's verified, right? So i.e. the transaction can happen, right?
Yeah, that's right. Data transaction is the last thing to happen.
So that would be the result of, let's say, a request. It's like a push-pull, but what would, let's say, the hospital or the payer use? That would be locally in the appliance.
So that there would be an appliance. So that's configured to a standardized specification. Maybe there can be vendor markets that are developing these appliances, but things that are compatible with certain specs that communicate with the national identification server. So as part of the server, you'd be either opening a marketplace for appliance vendors or kind of providing specs so that either if a network wants to develop their own, but basically the appliance is something that can a tool that can communicate with the server itself to do this tokenization framework. And that's why I said this is a high level. We don't have a market. This is really, really
No, I get it.
Yeah.
But so
Yeah.
in essence, if these two sites would have the appliance from the same vendor, right? Let's say, I mean, there could also be multi-vendors in the same institution, but if this would be the same vendor, they would know, once verified by the national identification server, exchange from this unique individual would be okayed. Am I understanding that correctly?
And the idea is that the specifications are done such that it doesn't matter the vendor, the appliance vendor. It doesn't. Basically, there are standards in place about how to build it, but the tokenization and how the tokens are sent back and forth between the server and the institution, those are standardized in a way that you can verify the process of verification of identity. It's vendor agnostic. The vendors can build stuff for it. You can create a system that maybe do it faster, or there's different ways to actually have vendors beat each other in the market space. But the idea is that the standardizations and specifications of communication should be the same, so that it doesn't matter which appliance vendor you're using. And it could be a home build as long as you comply with the specifications. And
the national identification server's role in this would be to track the interaction.
It's more than just track. It is doing the tokens. So it's receiving tokens, and in the server itself, it probably knows, there's either likely a dynamic ID, or every person has either a dynamic ID or there is an identification in there hidden behind firewalls, but that's not being passed around. That can be encrypted, that could have different layers. But the idea is that these tokens will pass information, certain metadata pieces, to verify that that person is who they say are, along with the tokens from the second institution itself. So it not only tracks, but it also does the it's able to aggregate the tokens and the messages that are coming in there to say, yes, this meets a certain threshold of identity. Yes, the data transaction can move forward.
So let's assume per vendor, this would require that the data model is interoperable between sites, at least, right?
Yeah.
Or would you propagate that, or would you propose that, for example, the purple and the green vendor should use the same data model?
I think they should use the same data model. I don't know what's the advantage of using a different one. I think there's a disadvantage, but I'd have to flesh it out more, find an argument for a different data model.
Yeah. So, when it comes to, identification and tokenization, that is something that I do have a lot of experience with. I'm not really concerned about the technology. I'm really, I got it when you laid it out last time. I understood exactly what you're trying to do. I'm more a little further down the road and just saying, okay, well, I like the idea, and it makes a lot of sense conceptually to me that this is something that's good for the industry and the market. How do we affect the change?
Yeah, how do we sell it? That's good. That's also more done, because Joe, as you're asking me, it's getting more technical, and I have to admit, this is not my area in terms of getting into the weeds. I had some high level frameworks, but let's flesh it out more. Who's the right partners on this? I mentioned about health insurance companies, but they're not going to necessarily, they could be strong champions, but they're not going to necessarily do that type of build. This is kind of cybersecurity infrastructure spending in some ways, as well as an HHS type of thing. So I'm trying to think which agency is really positioned to champion this. ONC is one. ONC is one of those things. I don't know who's head of ONC. They say, you know what? This has been a problem for all of us. This is one hypothetical framework, and ONC may not do the build, but they might champion another agency and have somebody else to do the build itself. Somebody's going to have to build this national identification survey. This could be opened up. Who knows how this can happen, but we need champions on the.
You're absolutely right, Joe. And from my perspective, I think that the technology is within grasp. I don't think that the technology is that difficult to implement. What's difficult is to get people to agree to it.
Yeah. Well, I floated one. ONC is one. And I guess we could start naming agencies in terms of governments, get champions, and then having them amplify the message. So, we're a small organization, so obviously, AMA, they won't be technical. So in some ways, I'm looking for a technical yet policy-driven type of organization. That's why ONC
Yeah.
came to mind. AMA is policy-driven, but it
So
probably
the
won't get.
so the other that comes to mind is the Agency for Healthcare Research and Quality, right?
Yeah.
AHRQ, because this is in the data, tools, and research realm, because this is not existing, hence research, and so that's more. And plus, I mean, I'm not sure whether the quality sector or quality section would be mostly applicable, but I think that's they have also grants and funding and do a lot of like private, public
Yeah.
or academic partnerships.
So where my mind gravitated, because I'm a business guy, right? What you're really proposing here is a solution for Medicare and Medicaid fraud, right?
We'll handle that. Will be a big proportion of what's going to happen with fraud. Yes.
Yeah.
And
Well,
also
they're the ones.
Yeah.
You know, I always look for, you know, who is, you know, losing money or stands to gain money by implementing this, and I don't see anybody gaining a lot of money. So it really, I think that the biggest buy-in has to come from someone who's losing hundreds of millions, if not billions of dollars a year, to say, yeah, we really need this as a way to
Yeah.
protect, you know, taxpayer dollars.
So that's CMS. That's CMS, right? HHS.
That's where
CMS.
my mind was gravitating.
Yeah.
Yep.
And I always thought they were operated through ONC. So that's why tackling ONC.
Maybe, I don't know.
Yeah.
But those guys, they got a lot of skin in this game. And if there's anybody that's going to throw some weight around, it would be them.
Good point. But yeah, I agree. I think that's where you should focus attention about, hey, get on their calendar. We have an idea. They might send the interns to go and listen to us as opposed to some of the bigwigs. But I think getting on their calendar just to say, you know, we were proposing something and we're hoping that it's going to lead to something bigger, get more, you know, sort of snowball in terms of, you know.
And when an organization like that backs it, it opens people's eyes and go, oh, well, maybe we better take a closer look.
I agree. So yeah, that sounds like I can't think of any better organization from that standpoint. All the rest of that I think are a little bit on the research academic side. You want to get folks that are on the wanting to get this out operationally. And I'm glad to hear that the technology's not that far off. I didn't think so. It's just an out of the box way of doing it because healthcare networks have not really thought this way. They don't really use tokenization on all that much. So this is a new way to kind of think about it, but it's not necessarily new technology.
No.
But what do you think, Joe?
I like it a lot. I'm just looking. I forgot whether this was the U.S. Surgeon General. There was a position paper not too long ago, I think, about medical misinformation. I think we may have discussed this here. Let me just quickly see if I can find it. But the medical misinformation, I forgot what it was called, but it's a very nice quick summary, and I think it was from the Surgeon General, and I don't know.
Yeah.
That may be because you mentioned this earlier, right? Where people think one way but may not fully understand what the implications are. Here, this is the advisory. And I believe that there are also grants associated with this. So this is kind of like,
yeah.
You know, so it may be.
Is this Vivek, the Surgeon General currently, or?
Yep.
Yeah. Huh.
So this is of course executive branch. I'm not sure how that ties together HHS versus AHRQ versus ONC. I think those are all different branches, different sections. Yeah, we need someone.
Yeah, we need an inside person, or at least some channel to get to somebody, just to get on somebody's teams, even if there's their intern, at least it's somebody that can make a difference just to get their ear on this. I think that's what we should strategize. I mean, whether it's Vivek's team or somebody at ONC, do we have anybody that's up there that we can just get on their radar?
Yeah,
I'm happy to pitch it.
I think
this is an organization that spends, you know, hundreds of millions of dollars just on identity verification at the point of service when somebody shows up at an emergency room. The identity verification portion of this thing is something they spend a great deal of money, and what you're proposing goes well beyond that.
Yeah.
Right.
Yeah.
So
they're
it's
really
the
good
ability
champions.
to centralize it. So all of a sudden, somebody shows up who, is supposed to be, Paul, but it turns out to be Joe. That's a big problem. It's going to become, immediately evident when the medical records don't add up to who's presented in front of me. Right.
Yeah. Yeah. No, it sounds like great champions. I think right now we need to identify some individuals that we have their contacts and just make a pitch. So can we get, to describe something? And then our hope is that we would like to operationalize or pick their brains about how to, if this is a good idea and they agree about it, they probably know their own stakeholders about who are the right folks to operationalize this. Whether, like I said, the build itself could be either government or it could also be the industry. They want to partner with some of the big old tech giants about how to do something like this. But the idea is there's coordination, private-public partnership in terms of something like this. The appliances are likely going to be private. They could be home brews and things like that. So there's a lot of private partnership, interaction on such an effort. But I think it starts with us sort of finding the right key players that are very interested. We know the organizations, but I'm looking at thinking.
Well, I think I can reach out to Mike Leavitt.
That's right.
Former secretary of HHS. He will know.
That helps. He's mainly on the digital part, but I don't know if his brother may, through really reaching out really far on the inside. Maybe you might know. Hey, we have something on, maybe a better way to do national patient identification, not identifiers, and maybe that might resonate on his network.
I think that's well spoken. I think that those are the key words that are going to make sense to the people who write the checks.
Yeah, not identifiers. Go say, oh, I heard this before. We got beat up. Identification. It's not this identifiers. We're not doing that here. We're doing a better way to identify, but not identification. Identifiers. It needs to be better spin. I don't know. It sounds so close, but we don't want to turn people off from prior failed efforts. Identifiers is just one of those things. There's going to be so much flack and resistance on that.
So it's in a way, the tokenization and verification part. So
yeah, if you can spin that, tokenization, verification. What's another word for identity? Just use a different word. This is kind of word wordsmithing and marketing it to somebody else so that it doesn't have the same connotation. And that ends up being research. That's the part I'm not too good at, this wordsmithing stuff.
Don't know.
Yeah.
Credentialing is sometimes used interchangeably.
Credentialing.
Yeah, in medicine that has a slightly different connotation, but
and it has to resonate with them about misidentification. Using that word, something that resonates. This handles the problem about misidentification. What's in their language, and that resonates for them.
The word that's going to get their attention is fraud.
Fraud, they're in. Better way to avoid fraud. Yeah. Fraud prevention.
Identity verification.
Yeah. Identity verification, fraud protection, fraud and mitigation, fraud aversion. Those are some keywords.
It's a little bit of a crafty way of selling something that not really what our intention is. But
it's not. We come from a good place, and it's a good endeavor. Right. I don't think there's anything. I can live with myself on the gates of whichever place after that. So.
No, this is, as you mentioned, very high level. So, the part that I was at least hearing initially was, if you have, I don't know, we're running out of colors here, but if this is the actual content, right? So this is the payload or whatever, right? This is the actual data, and that's the metadata in a way, an ID.
I can't really see your screen.
Oh, I'm sorry. I stopped sharing.
Yeah. Paul, it sounds like this is viable. And let's say if we don't hear anything from Lauren next week, I'm happy to just put it up there. We're good. I can stand by it. It seems like I haven't heard anybody say no. So, I mean, that's just maybe me being overly cautious about putting something out. But my chief information security guy is a white hat hacker, and he's a pretty good one. So, and he said, oh, it makes sense to him. And obviously, I'm glad it makes intuitive sense right off the bat when you look at it. That's the hope. It was one of the things, yeah, that makes sense. You know, that's the gut reaction I wanted.
And in terms of selling the concept to politicians, you know, the idea of protecting identity, you know, protecting somebody's personal information, while at the same time improving our ability to identify and protect ourselves against fraud, is going to be something that's going to, you know, really hit a lot of the buttons for that.
I like that. Protecting identity.
You can protect us from wasting money on fraud with people who aren't supposed to get benefits in a way that doesn't require them to give all of their information and expose all their PII to everybody as part of the process.
That's the spin. Protect. That's great language in terms of really resonating with a politician. Protect.
Decentralized. Wait.
Decentralized. I hope the politicians, some are smart, some are not. but a big word.
That flies well on the right, because anything that you don't have a central repository for, I think, is what they are trying to avoid. I mean, I really didn't know anything too much about tokenization, but this seems like a pretty well-established concept within the finance industry.
Yeah, absolutely.
So
it is. It is.
Yeah,
I'm surprised.
Honestly confess that I don't know much about it, but.
Yeah, I'm surprised that when they had Bezos and all of them doing that one effort between Amazon, I'm surprised they didn't really think of that. But you know, and that's why I'm always hesitant to put something out. Well, somebody might have thought of it, but
so like I said, you know, I do have a lot of experience. These ideas are not new; it's the application that's new.
Yeah.
Right. The technology exists. I mean, RSA is a company that's built on this. This is what they do, but they haven't really moved into this market with this type of an application because it's something that most likely they spotted a lot of resistance for all the reasons that we've already discussed, and haven't had the right players at the table to say, you know, actually this is doable, and it's for a good reason, because it gives us not only the protection over here, but it also enables greater sharing of medical records for everybody down the road.
Yeah. That's great. I'm glad this is recording, because I then recorded so I can. Those are the types of things I need to jot down. Those are good.
I think one element there to follow up on that, Paul, would be to talk to malpractice insurance and, you know, legal companies and or malpractice insurances, because the control of medical record data and access to it is obviously near and dear to their heart, especially when it comes to fraud, right? Because you not only you will have to have the burden of demonstrating that was the intent, not only by accident, right? Like a data set was shared or part of a medical record was uploaded falsely, or, you know, an identifier was switched, or a database wasn't audited right? All these components get into this. So I think that may be typically a thing like who is responsible, who's the data owner, and you know, the other part is obviously this may be a fantastic topic to discuss under the HIPAA revisions, right?
Yeah. It was actually part of HIPAA anyways, everybody knows here. So we're not actually taking something away. We're just trying to follow through on something that was promised back in the 90s.
Absolutely. It's one of the P's, right?
Yeah.
Portability. I don't see much portability, right?
Protecting portability. I mean, you put these words together, it makes me kind of put a tear in my eye. So, I mean, it must resonate with a politician. You know, I had one more thought, Joe. You know, would Brandon have any other contacts? Like, would he be somewhat, I mean, government's a big place, but would he know somebody that might have some ties with Vivek's team, Surgeon General, being kind of somewhere within, you know?
Well, I think if we reach out to Mike Leavitt, I mean, as the former secretary, he will know the branch, you know.
Yeah.
I think there are operating divisions, and there is the office of the secretary. Those are the two big branches, and within that there are, I don't know, 40 or so different, you know, subsections and offices and agencies and centers. And, you know, CMS is under one of the operating divisions. So within CMS, there's probably several to talk about it. But I'm not too familiar where exactly this would fit in. But I think this is touching on some very iffy legal issues as well, right? Because clearly the 21st Century Cures Act incentivized everyone to work on interoperable solutions. That's a demand. But it's the same thing like we discussed earlier with the information blocking. So what if you're not interoperable, right? You can say you're interoperable, but the APIs still have to be built, or the API is not there, because all of what you propose is that it's not only the same data model, but that it would follow a certain format. That's a standard that would have to be established, and that either evolves naturally or someone actually hardcore designs it. And I don't know how that worked in the credit or finance field. Plus, I believe the payload for a financial interaction is a shorter string than a full medical record with various formats and contents, right?
Absolutely. Yeah.
Yeah. I mean, actually thinking about the information blocking, in some ways we're information blocking because we're taking so long trying to verify people's identities. So in some ways you can make the argument that this actually greases the pipelines to make things go flat. This actually is part of the helping avert information blocking. So there's a lot of strong arguments to be made with initiatives that are ongoing. The information blocking, that was ONC too, right? So
correct.
Okay, so it's the same folks. All right. So it sounds like Leavitt.
So they're called the national coordinators, right? So this should fall within the realm of that. But I think I can check the recording. There were some contacts on there, and we can summarize this somewhat succinctly. It may be good to just talk to them and say what they think about it.
Yeah, we'll make a pitch. Stick around, make a pitch, something that's not too long, and using the keywords protecting, privacy, fraud, some buzzwords, and hopefully get the attention.
What would a demo of some concept like this look like, Joe?
Well, I can't tell you in healthcare, we don't have one, but maybe we have one in the finance industry or something that's similar, that's happening elsewhere in a different industry, and seeing how effective it's really dealing with the load. Something that could be translatable to this. That's the part that we won't find anything here in healthcare, but and Paul, maybe I'll ask you, if you have any examples that might be close to this.
Sure, it's identity theft. I mean, that's what you're talking about.
Yeah.
So when somebody takes your financial identity, that's a mess.
Sure.
What happens when someone takes your medical identity is that Medicare and Medicaid get defrauded, first of all, potentially. And also somebody could get access to your medical records or corrupt and take over your medical records for, I don't know, undetermined nefarious reasons. I don't know what they do when they got in there, but the bottom line is I see this as a solution to the obstacle that we began this discussion talking about, which is blocking, right? Yeah. This is a solution around blocking, at least one aspect of it, which is people who are concerned about sharing medical records that they will have PHI in them. This is a way where you could at least remove one big chunk of it, which is name, address, social security number, and other demographic things from that list.
Yeah, that's right.
There's always going to be PHI inside the EMR if somebody really wants to prowl around down there. But at least from a header perspective, it makes things a lot easier to share and aggregate when necessary.
That's great points. Actually, I didn't even think of that, but that's right, actually, because when you do the data transfer, the last step where everything happens before and you verify, you don't have to actually transfer all those important PHI things. The data transfer is really strictly the important stuff, and you can strip it. You actually lessen the amount of valuable content in that data stream by doing this.
Correct.
So.
Correct.
Well, Joe?
I like it. I think this is this will be hard to explain without an example,
Yeah.
because as a concept it is easy. But if you say, for example, I have a name attached to an X-ray, and I upload this to somewhere, and let's say I have the bit stream and I have an identifier on top of it that identifies that as my X-ray, and now I want to strip the identifier, get a token for it, and with the token people could grab that information from another site and identify whose X-ray this is. It would have to exist as a sort of push-pull query before the data is available. So it's kind of like a two-step removed from getting to the X-ray, if that's the information that's supposed to be transferred. So,
Yep.
so the example would be, I want to share a mammography, and the patient identity is necessary to make sense of the image. But before I share the image and before I share the identity, I share a token that verifies that you have the appropriate infrastructure to accept the data in a certain format, but you have to give me your token, right, to say that that is the right patient or the right query. So the question technically that makes it somewhat tricky for me to understand is, the one institution could push the data and say, we know that you will see Mrs. Miller, but we send you the token, so the other side will have to create a token for Miss Miller to identify that that the other institution can grab the information. But that requires some sort of accessioning of Miss Miller.
Yeah, I haven't thought about that second stage of data transfer. I left that part out.
Or the token would be basically available at all sites at all time until you have some other independent identity of this to create the matching token, right? So without a request, a push would just sit as token, very like low data volume, as a potentially shareable ID. But to get the matching token for receiving that, usually in the finance sector, it's just no one cares as long as you have the money being pushed to, let's say, where you put your credit card in. So in a way, the requesting the medical information could trigger something, right? So if you take the reverse instance, I'm at a new hospital and I want my X-ray, I create the request with an ID that's removed, tokenized, and now I'm asking, can you send me this? But then there has to be a request from another site, but that doesn't have the token yet because the request has to come. So it's kind of like we're trying to, the token still has to be exchanged.
Oh, I guess the part I might have left out in the first stage, that, and maybe as part of the process and verifying that it might be not just one institution talking to the server, but maybe two. And so the server does reconcile that there is going to be a communication between these two entities.
Yeah.
So it's following a transaction. It knows a transaction is coming. So in some ways, it's brokering it to some extent.
But if, let's say we use MGH and MSK, if I have 4 requests, entirely anonymous requests that are tokenized to get cases from you, how would you know which 4 cases I mean?
The 4 cases, I assume, well, the cases might be either from the same patient or different patients, but the national server would actually sort of know, okay, this case belongs to either patient 1, 2, 3, 4, or the same patient. It would know that, but it would also communicate with either with Brigham or Mass General or with MSK to say that this is coming your way. To have that there's going to be either a unidirectional or bidirectional flow between data between the two institutions, because it's communicating with the appliances between the two institutions. So it's kind of brokering a transaction.
The key is that there is an independent broker between two institutions.
Yes, that's right.
Who is not
it's
government.
a series of public and private keys.
Yeah.
Yes. I mean, that's a whole business ecosystem in its own right, I guess. Serving as an independent tokenizing mechanism, which is independent of the actual data holding entities.
Right. Well, it's a clearinghouse for the transactions is really
Correct.
what's in the center.
Yeah. Like, these credit card companies.
Yeah. The finance is actually a very good paradigm for this.
I
They've
think
got a lot more at risk, that's for sure.
but I think going through a use case like that in like practical terms, I think that may be helpful to just say this is how it currently works, because you have to say I'm Mr. Miller, Mr. John, or whatever.
You do a walkthrough and see how this
works. Is there a synthetic model data set that we could kind of create that would
that'd be cool
to demonstrate this concept in some way? That's what I was thinking.
Well, this is the part I haven't gone that far into detail because every institution relies on a certain number of metadata to verify the validation. What I'm arguing is that you don't actually need a standardized module. You just need a certain number and it can be calculated. Once you have 10 of these elements, you've met a certain probability threshold that you are who you say you are. So it doesn't necessarily have to be the same data that's there. So, some people, they may not have certain data that's missing, but if you have these others, they kind of aggregate together. But I haven't actually wireframed in my head exactly what that data is, because that actually requires somebody who's really an expert on PHI. What's the probability once you have these 10 elements that you are who you say you are? And then you can actually have a whole catalog. When you aggregate those together, you can calculate the probability that who you say you are has this false negative rate and sort of build a threshold off that.
All right. Sorry, guys.
I know,
we have to stop here. It's 4 o'clock.
Call.
Hey, thanks a lot. This is fantastic. Thanks.